Welcome. Thank you for joining us. Our next presenter is Dr. Celine Etches. Dr. Etches is a child and adolescent psychiatrist at the IWK Health Center and serves as an assistant professor of psychiatry at Dalhousie University, Halifax, Nova Scotia. Dr. Etches has specialized training in addictions and mental health with research interests in risk and protective factors for adolescents' substance abuse. She is here to present a case review of a 10-year-old boy with Prader-Willi syndrome who has been experiencing cyclical catatonia. Please welcome Dr. Etches. Thank you.
Thank you very much. I'm very pleased to be here. So as was mentioned, I'm going to speak about periodic catatonia in a young 10-year-old boy with Prader-Willi syndrome. I'm hailing from Nova Scotia in Canada, and that's where this individual is from. I have no disclosures. So this is a 10-year-old boy named Elliot. That's not his real name. His parents asked not his real name not be listed. He has an unknown variant of Prader-Willi syndrome. It's likely maternal. We know it's not paternal in origin, so it's likely maternal uniparental disomy. His parents elected not to go further, finding out the cause at this point. He is on growth hormone, and he uses a CPAP machine at night for obstructive sleep apnea with no difficulties with that. He was developing within normal limits, a lovely, sweet boy, until about January 2020, when he had this sudden short period of quite significant fatigue. No cause was found for the fatigue. It lasted a few days. And then he began having these fluctuating spells, which were quite strange. They took two distinct forms, and these were interspersed with normal baselines of periods of activity. So in the first form, he became quite quiet and mute and wouldn't respond to commands or requests or interact with his parents or siblings or teachers at school. His teachers at school actually wondered if he developed selective mutism and actually questioned if perhaps he had a concussion. He would engage in aimless wandering behaviors with no purposeful direction, and at one point left the house and was found by the police wandering along a nearby highway and seemed to be in a daze. He would hold his hands up, clenched in a kind of fixed position, fixed posture, and stare very blankly into space. And he'd have some very strange facial grimacing. These would last about 1 to 3 days initially, but then progress to last even longer. Another striking feature in these spells was that he wouldn't be interested in eating or drinking at all, and food would be placed in front of him and he would not show any interest. He also had new onset incontinence in this phase. So I'll show you a small video clip of what this would look like for Elliot.
Is that lunch for me? Who's that lunch for? It's not mine.
So as you can see, he really didn't respond, and this would go on for days, and he wouldn't eat. And then he started developing another form of spells where he would be very agitated and begin laughing suddenly to himself and turning in rapid circles and screaming and yelling and talking to himself. It seemed like he was having interactions and talking to other people. He also became newly aggressive to his mother and his siblings and would slap them and say, "Shut your mouth," which was completely out of character for Elliot. As well, interspersed in those agitated spells, he would have these onsets where he felt that something was wrong with his body and scream about his bones. There was something wrong with his bones, and felt that people were monitoring him and people wanted to kill him. And that at times his brother wasn't actually his brother, and that he wouldn't let his brother into the house because he thought that his brother was trying to kill him. So let's view a brief clip of this.
I'm really sorry, but they are tough people, adults, and they just blew up my own mind, and then we hurt my feelings. I do not care. They have to go to jail to do this. My backbones hurt everything. My backbones, my hair, and the
So obviously very, very agitated, very upset. It breaks your heart to see him like that. This is not his normal state at all. And then oddly, he would have periods where he would revert back to completely the same Elliot that they had known his whole other previous 10 years of life with no absolute difficulties. So, but what was happening is that the episodes were getting more frequent and lasting longer. And so when he came to see me finally, he saw neurology and he saw endocrinology and he saw a lot of people. And then he came to see psychiatry in the summer. So these battles had been going on since January at that point. And at that point, I diagnosed him with catatonia. And I was highest on my differential diagnosis was this periodic catatonia, fluctuating between the stuporous form of catatonia and the excited form of catatonia. So catatonia is actually quite common in children and adolescents. It's under-recognized even within the psychiatric population. But you can see that the common catatonic symptoms in children are often viewed as the stuporous phase, not so much the excited phase, but we really can recognize the stuporous phase much more easily with mutism. This posturing, the facial grimacing is often quite classic, staring blankly into space, and the new onset incontinence is often very classic of this condition. So for Elliot, by August 2020, he was spending about 80% of his life in the stuporous phase, 5% in this excited / paranoid / possibly psychotic phase, and about 15% in a normal baseline state. So his functioning was significantly impaired. So as I said, pediatric catatonia is actually quite common in children and adolescents. It's got a 5% prevalence in your general outpatient population, but 12 to 17% actually of adolescents and young adults with autism and developmental delays. And this would include Prader-Willi syndrome. And then we can move into our severe psychotic illness, particularly bipolar disorder, where we get quite a high prevalence as well. We know that most catatonic episodes occur in puberty, and it's more common in boys than in girls. It's not a diagnosis in and of itself. It's like delirium, so it's a symptom of an underlying diagnosis. And in that, it's actually one of the only two psychiatric illnesses that fluctuate. Delirium fluctuates throughout the course of a day to weeks to months, and catatonia also can fluctuate. But usually, to be honest, you don't see it as profoundly fluctuating as it was in Elliot's case, with these very clear different poles of the catatonia, and also not this very distinct normal baseline periods as well. So it can be a symptom of many, many illnesses, ranging from lupus to autoimmune encephalitis to bipolar disorder to effects of taking too much MDMA or ecstasy. So lots of different things can cause it. So it's really a sign that something's going wrong with the brain and you need to work this up. But as I said, it's also common in developmental disorders, including Prader-Willi syndrome. And we'll talk a little bit about why that is. It's difficult to diagnose, of course, in people with developmental disorders because a lot of the symptoms that are classic for catatonia are also often seen in the normal course of developmental disorders like Prader-Willi and like autism. So things like mannerisms and being mute sometimes, or perhaps repeating things someone said like echolalia, being somewhat negativistic, engaging in some stereotype behaviors, those can be a normal baseline. So it has been proposed, should we have specific criteria for developmental disabilities? And the thought is most likely yes, because this is very difficult using our standard criteria scales. We use a scale called the Bush-Francis scale, and we use a scale called the Pediatric Catatonia Rating Scale. It's a challenging scale to use in individuals with developmental disabilities. So really the bottom line that we say with youth with developmental disabilities is if there's a new onset regression in their functioning, in their activities of daily living, if they're increasingly passive, if they're slow to do tasks that they could do easily before, think about catatonia in your differential diagnosis. Why that is because it can be actually a fatal condition. This can progress to something called malignant catatonia, which is like neuroleptic malignant syndrome, where you can actually die and mortality can occur. And it's important too, because now, as you can see, at this point, when I saw Elliot, we'd already spent about 6 months of his life progressively not achieving his developmental milestones. So it's important to recognize this and to intervene early. So in terms of Elliot, we did a full medical workup and everything was found to be normal. There was a mild epileptiform discharge in his left occipital region on EEG, but that had been there on serial EEG since birth. And so neurology really felt that this didn't represent seizure activity. I only listed some of the workup we did. It was a very exhaustive workup. Everything was negative, including a negative MRI. So it was really felt that there was no medical cause that we could find to explain this. So then it turned to, okay, how do we treat this? And the hypothesis with catatonia is that this is a GABA and glutamate imbalance, that you have not enough GABA and too much glutamate. So GABA is kind of our inhibitory neurotransmitter in the brain. It's kind of the brakes of the brain to say, slow down, don't do things. And glutamate's our excitatory neurotransmitter. And the thought is in catatonia is that there's this imbalance of too little GABA, too much glutamate, and you basically flood the brain with glutamate and it kind of freezes, stalls up, too much gas, and it overloads the engine. And why it's important in Prader-Willi syndrome is because there is links between GABA and catatonia to chromosome 15, which of course is the chromosome linked to Prader-Willi. And this chromosome region contains a cluster of 3 GABA receptor subunit genes. And the loss of that key part in chromosome 15 results in a loss of GABA receptors and their receptors. It also shows, when we do PET scans of individuals with Prader-Willi, there's a reduction in GABA binding sites. And there was a recent study out of Australia that showed that there's a reduction overall in levels of GABA in individuals with Prader-Willi that correlated with behavior problems. So GABA is clearly very important and it's linked to this chromosome system. So when we manage catatonia, it's really, really important. You think of catatonia as kind of like an egg with the underlying medical condition or the mental health condition causing the catatonia being the yolk and the catatonia being the white part of the egg. And it's really, really important to pull back that white part of the egg and get rid of the catatonia before you or concurrently as you're treating the physical and mental health condition, because if you don't do that, you really can't penetrate into the underlying cause and treat it effectively. So there's lots of different ways when you think about that neurobiological hypothesis of not enough GABA and too much glutamate. How do you increase the GABA and how do you decrease the glutamate? So lots of medications can do this. And so you can see some of them there, that if we could increase the GABA with benzodiazepines, particularly Ativan or lorazepam, zolpidem is another one. They use that more in Europe, actually. Valproic acid increases your GABA, carbamazepine, topiramate. Some of these you've probably heard of for Prader-Willi, particularly topiramate, which is used for some of the compulsive behaviors. N-acetylcysteine is another one. Which is more on the decreasing the glutamate side, which you probably have heard about for the decreasing of the skin picking disorder sometimes in Prader-Willi, but also to decrease glutamate, memantine, amantadine, topiramate, clozapine. So you can choose kind of, if you think this is on your differential, what would you use? Other options are lithium to possibly increase the GABA, CBD oil, which we just heard about in the last session, that acts on the GABA system. And currently there's a trial, again, coming out of Australia, testing a camprosate in individuals with Prader-Willi syndrome for behavior issues, again, decreasing that glutamate. So what we did with Elliot is that we started him just kind of on something very benign. So started on N-acetylcysteine and thought, okay, let's try that. There's evidence with that. Started at around 900 milligrams twice a day. Didn't really do very much. So we moved then, and we also gave him some Ativan, which parents were kind of intermittently giving to him. They weren't that convinced that that was particularly helpful at 1 milligram, and were a little fearful of giving more in that setting. So then we proposed various other options, and they elected to do a trial of valproic acid. And one of the reasons that we did valproic acid as well is because there is, with the fluctuating nature of his catatonic episodes and the nature of the periodic catatonia features of it being very much between the 2 poles of excited and stuporous, I wondered if perhaps this represented a form of early onset bipolar disorder, perhaps, which is more common in that maternal form of Prader-Willi. So we elected to try the valproic acid. We titrated it to a total dose of 500 milligrams twice a day. And the agitated catatonia, that excited with the psychosis, completely resolved. But unfortunately, there was minimal impact on the stuporous, or also known as retarded catatonia phases. And those actually started progressing till he was almost completely always in that state. So I also debated, because they were saying, well, he's talking to people, he's not there, he must be psychotic. So we did consider briefly antipsychotics, but the problem is when you have catatonia, you really want to avoid the antipsychotics if you can, if there's active catatonia, because you run the risk of precipitating malignant catatonia. So that progression to very destructive catatonia that can actually be fatal. So I elected not to use the antipsychotics for him in that case, because again, that stuporous catatonia was his prominent condition. We then brought him into hospital and did a lorazepam trial. And it was around the 5 milligram mark of lorazepam. Once we had given him 5 milligrams at around 3 hours, he suddenly stood up and said, "Could you please get me something to eat?" And this was the first sentence he'd said in a few months. And then he started singing Jingle Bells with me. This was around Christmas. So at that point, I said, look, you know, we're not going to make a difference with doing regular around-the-clock Ativan, and that's something the parents didn't want to do. So we moved to a trial of electroconvulsive therapy, ECT, which has a very high response rate for catatonia, and is the treatment of choice in that condition, actually, if catatonia is progressive and has been lasting a long time. He had 8 sessions of ECT. These were bilateral ECT, which is the treatment of choice. They were only twice weekly, which was not ideal. We wanted 3 times weekly, but just to pressures on the hospital system and COVID, we couldn't get the 3 times weekly, unfortunately. He had an 80 to 90% recovery. We then elected to stop, and then he had a 3-week complete recovery. And he is now having some brief return to occasional agitated states. So that is the end. I know we're at the end of the presentation. I have just a brief video to show you. I'll play this for 1 second and then we can answer some questions.
So what are some things that you think that a dog would need if we get a dog, huh? We have to stay still. A what?
A feeding bowl.
A feeding bowl, yeah.
A bowl, a dog bowl.
Yes.
So I know we've run out of time there. So I welcome questions on this very interesting and challenging case.
Thank you very much. That was a very interesting and important characterization. So we do have some questions. One of the questions brought up the relationship to porphyria and whether or not that was explored as an option. And another had talked about cycloid psychosis, which has been seen in Prader-Willi syndrome. And could you compare or address those 2 questions?
Yeah. So the acute intermittent porphyria, he'd had no other signs of that. We didn't actually test in the, and because the episodes were so dramatically long with the stuporous catatonia, we didn't test exactly for acute intermittent porphyria, but he didn't have many of the other classic signs of that condition. And the urinalysis and other things like that were normal, but you're right, we didn't do the 24-hour testing for those. But again, he didn't have many of the other classic features. And in terms of the cycloid psychosis, yes, that was raised as a possibility, absolutely. The difficulty with psychiatric illness is that, you know, our naming nomenclature is so challenging. And so was this, you know, periodic catatonia, or was it excited delirium, or was it, you know, so ultimately it was kind of, well, I'm seeing, you know, I did it symptom-based and said, I'm seeing mostly stuporous catatonia. I really want to avoid any sort of risperidone or even aripiprazole here. Let's move to treating this as if catatonia and the fluctuations between the poles. Because when you do look at the descriptions of cycloid psychosis, there are many catatonic features within that. And so you could just as easily name cycloid psychosis fluctuating catatonia as well.
Very good. Well, and I think the end result is, you know, a healthy patient. And so I think that tells the story. I see there's another question that if this were to present in PWS individual with a paradoxical reaction to midazolam and other benzodiazepines presenting with aggressive response, what would another course option be?
So I guess the question is if the person was catatonic for a long period of time and then had a paradoxical disinhibition response to the benzodiazepine, that's actually a very good sign. That's a sign that you're on the right track, that catatonia is your diagnosis and that you probably would want to move to ECT. If it's just someone who's developing normally and just has a paradoxical response to benzodiazepines without catatonia at baseline, that's just, you know, a typical thing that we often see in kids with developmental disabilities, and you just avoid benzodiazepines and probably diphenhydramine as well. You might see that. But actually, it is a good sign if you get some disinhibition in a benzodiazepine trial.
And then I had a question about lithium as
Yes.
an option. Did you,
Lithium's definitely an option because it can raise your GABA levels as well. And there's evidence of lithium being effective in the cycloid psychosis literature in that case series for youth with Prader-Willi syndrome. So it definitely would have been an option. We just went with valproic acid because there's just more evidence for that being a higher GABA stabilizer.
and then I have another question. Have there been many issues with prescribing the higher doses of lorazepam as the US is highly controlled?
Not in Canada. I think that we maybe don't have as many of the same restrictions. Similar, we don't have this restrictions with ECT either, which I know is state dependent for the United States. So no, I mean, and sometimes you have to go up to 30 milligrams a day to effectively manage this. So we haven't had a challenge doing that.
Fantastic. Well, wonderful. Dr. Poggi, do you have any other input?
No, I just want to say this was a very, very, very nicely done presentation and an excellent review of catatonia. So I think that the issues in the course that was described resulting in ECT is actually very classic and definitive management. So thank you very, very much, and just fantastic review of considerations and management. So again, thank you.
Fantastic. Thank you so much. I think we have to wrap up. So wonderful talk. Thank you so much.
Thank
Please
you.
don't forget to complete your surveys if you don't mind. Thank you again.